Hello, everybody. This is a talk which will discuss why karyotyping still matters in an era where so many other advanced techniques are still available. And today, I will not be going into the procedure of karyotyping. However, we will look at karyotyping from the practical perspective of a clinician and a pathologist. So, the question which everyone asks is that in this time and age when we have superior techniques such as next generation sequencing, whole genome sequencing, RNA fusion panels, optical genome mapping, do we still need karyotyping? And my answer to that is yes, because chromosomes still tell us stories that genes alone cannot tell. Let us now look at how genomics evolved. In the 1960s, when karyotyping was started, we looked at the whole genome view. We looked at the number of chromosomes, whether there were translocations in the chromosomes, and it gave us an overall view of whether the chromosomes were normal or abnormal. Fluorescent in situ hybridization came here in the 1980s and the 1990s, where we could detect um, structural abnormalities if we knew what the exact target was. In this case, the target had to be known, and you could use a complementary DNA probe to determine whether that abnormality was present or absent. Array comparative genomic hybridization came in the 2000s, which detected copy number variation, and also we had single nucleotide polymorphism arrays, which did the same thing. Now, in CGH, what we did was compare the DNA content of the patient with the DNA content of a human reference genome. Now, what we do here is to tag this DNA with different fluorescent probes, and this entire thing is hybridized onto a microarray and then detected. Um, Now, in this case, remember, we are detecting DNA content and not looking at chromosomes. So, if the fluorescence was more, it probably meant duplication, and if the fluorescence was lesser than expected, it probably meant deletion. Now, remember that CGH, or comparative genomic hybridization, cannot detect balanced translocations. The reason is the DNA content will remain the same, whether it is a balanced translocation or an inversion, you will still have the same DNA content. So, for that, you will still need karyotyping, and CGH will not work in that condition. In the 2010s, we had next generation sequencing. Now, this job of next generation sequencing is to read the entire genome as a spell checker or a proofreader. So, this detects small mutations and gene fusions, but it has a very high resolution compared to karyotyping. But remember, when you do next generation sequencing, you're so focused on the spell checking that you will probably not realize if there is a large um, deletion or insertion. Um, and optical genome mapping is a technique which detects larger structural variants. It almost creates a physical map of the entire genome. And compared to karyotyping, it is more convenient because it does not require the tedious process of culturing. So remember that each of these technologies answers a different biological question, and no one method has all um, perfections. Every method has its limitations, and whenever you order something, you will need to know what the strengths and weaknesses of that method is. So this depends and this determines um, what your clinical question is and so you will choose a method appropriately. So this is a chart which shows you a comparison of the entire toolkit that we have in cytogenetics. Let's start from here. Karyotyping has a low resolution, but it can look at the entire chromosome. It uh, detects balanced translocations. It can give you an idea of ploidy. Ploidy is where you're talking about complete chromosomal sets. So in human beings, diploid is when you have 46 chromosomes. When you're saying haploid, you're talking about 23. When you're talking about triploid, is 3 times, and uh, tetraploid is 4 times, and then polyploidy. So whenever you have multiples of 23, it is polyploid, and when you have something which is not a multiple of 23, it is aneuploidy. So the disadvantage or limitations are that this requires live cell culture, and as I already said, it has a low resolution. Compare this with fish, which has a medium resolution. But the problem with fish is you must know what is the target you're looking for. So if you know what the target you're looking for, it's a rapid technique. Compare karyotyping with fish. In karyotyping, you are detecting the chromosomes in metaphase, which is in the mitosis. In fish, you are looking at interphase. I already talked about array-CGH or comparative genomic hybridization. This has a high resolution. It's very sensitive to detect deletions and duplications, but it will miss balanced translocations and inversions. Optical genome mapping has a high resolution. It detects large structural variants. It detects complex rearrangements, and the advantage is it does it without culture, but it does not detect small point mutations. Next generation sequencing has a very high resolution at the level of the nucleotide. It detects single nucleotide polymorphisms and spelling errors, but it is difficult to visualize the global chromosomal context because it's so focused at the nucleotide level. So I hope this helps. Let us now look at what each genomic test actually shows. Let us imagine that the entire genome in our body is like a book. So, what next generation sequencing does is that it works like a proofreader. It goes through every page in the book and tries to read the letters and see if there is any spelling mistake happening there. It answers the question what specific mutation has occurred. On the other hand, karyotyping looks at each page. So, has every chromosome present there? Is it proper? So, is every page in place? Have the pages been rearranged? And uh, it therefore looks at the physical architecture of the chromosome or the book. Now, both these techniques are complementary, both are necessary. Two tumors may share the same mutations, but they might differ entirely in chromosomal instability and ploidy. Now, let us look at three things that karyotyping does best. One, it gives you an overall view of the entire genome. So you can identify both balanced and unbalanced structural rearrangements across the entire genome. Second, it helps you look at complex karyotypes, and if there is chromothripsis, where there is shattering of the entire chromosome because of a single catastrophic event, you can see the actual damage that has occurred at the chromosome level. Remember that in cancer, you have a single clone, which again differentiates into several subclones. And therefore, through karyotyping, you can see if there is a single mutation or if there are multiple mutations throughout. And this helps you to determine if there is clonal evolution, which perhaps means that the prognosis is worsening. You can have visualize massive structural changes like your ring chromosomes and double minutes. And obviously, you can look at and see if there is triploidy, tetraploidy, or polyploidy in the karyotype. What I'm going to do now is to discuss 6 clinical cases. Let's come to the first clinical case, which is the classic um, paradigm. It is a 45-year-old man who presented with fatigue and abdominal fullness, and he had splenomegaly. The WBC count was markedly raised, and the peripheral smear showed presence of myelocytes, metamyelocytes, and basophilia. So our obvious diagnostic question here is this a chronic myeloid leukemia or is this a leukemoid reaction? And for this, we need to see if there is a Philadelphia chromosome. The Philadelphia chromosome, as you know, is a reciprocal translocation between chromosome 9 and chromosome 22. On chromosome 9, you have the ABL or the Abelson gene, and on chromosome 22, you have the breakpoint cluster region or the BCR gene. And when the ABL breaks and attaches close to the to the BCR gene, it leads to this BCR-ABL fusion gene. This is a balanced translocation, and the presence of this BCR-ABL fusion gene leads to constitutively active tyrosine kinase activity. This means that there is going to be a unregulated proliferation of the myeloid series of cells here. There is going to be decrease in the apoptosis as well as increased survival of the cells. The reason why we want to look for this ABL BCR fusion gene also is because we have imatinib, which is the first discovered inhibitor of tyrosine kinase. Now, imatinib goes and sits in the ATP area of the BCR-ABL fusion gene, and it allows it stops the proliferation of the myeloid series of cells. As you can see here, there is a translocation between chromosome 9 and 22. Now here, why does karyotyping matter in this case? Yes, it helps you to confirm chronic myeloid leukemia. Um, and you can also detect BCR-ABL fusion with FISH or PCR. Now, besides telling you the diagnosis by determining the primary clone, uh, karyotyping can also tell you if there is a duplicate Philadelphia chromosome or if there is a additional trisomy 8 or an additional isochromosome 17q. Now, the presence of these additional chromosomes means that there is a clonal evolution, and these changes indicate disease progression. Now, you can see that karyotyping can help in many ways. One of the ways is by monitoring of the disease, where if you count the number of metaphases which has the presence of the Philadelphia chromosome, that percentage will tell you whether the disease is progressing or not. Uh, Therefore, you can see that karyotyping reveals disease biology and clonal evolution and not just gene fusion. Let us move now to case 2. This is a case of a 32-year-old woman who presented with bleeding gums, petechial hemorrhages, and fatigue. The laboratory findings showed that the platelets were low, she had thrombocytopenia, and the peripheral smear showed presence of abnormal promyelocyte with OR rods. I think here the diagnosis is obvious. It is a AML, and it's most probably acute promyelocytic leukemia. But it's important to confirm this diagnosis because APML is a diagnosis which requires immediate treatment. So here, for confirmation, we are looking at a translocation between chromosome 15 and 17 to see for the PML-RARA fusion. Now here, in case there is a fusion between PML and RARA, you have a specific treatment which is the all-trans retinoic acid, and this is a life-saving therapy. Now, karyotyping matters in this case Here you can see a translocation between 15 and 17 because AML-M3 or acute promyelocytic leukemia is a medical emergency. And what ATRA does is allows the promyelocyte to differentiate into neutrophils, and therefore it controls the number of WBCs in the body. It's not a treatment, it only helps by differentiation of the promyelocytes into neutrophils, which die after their half-life is over. So, identification of this translocation allows treatment with ATRA, which dramatically improves survival. So, this is an example where cytogenetics directly saves lives by confirmation. Let's move now to the third clinical case. This is a case of a 70-year-old woman who presented with fatigue. Her laboratory findings showed that she was anemic, her hemoglobin was 8, the WBC was normal, but the platelets showed an increase. The bone marrow showed dysplasia in the erythroid lineage. She had a normoblastic erythroid proliferation, but some of the erythroid precursors demonstrated some form of nuclear cytoplasmic dyssynchrony. The neutrophil precursors appeared normal, but the megakaryocytes showed hypolobated nuclei. We are suspecting a myelodysplastic syndrome, but we want to see if we can identify the correct subtype of the MDS here and initiate correct therapy. Suppose you get a deletion of 5q. In this case, we have a specific therapy available. So it is important here to see that this patient had the 5q deletion. Now, this specific abnormality has a distinct morphology, it has a better prognosis, and these patients respond to lenalidomide therapy. So, this is a clear example where karyotype defines a disease subtype and it guides therapy. Now, let's move on to some other non-hematological cases. This is a typical case of a 16-year-old boy who presented with painful swelling in the right femur with fever and weight loss. The radiology showed a destructive bone lesion in the diaphysis of the right femur, and the biopsy showed the presence of a small round blue cell tumor. So your differential diagnosis here consists of Ewing sarcoma, lymphoma, and also rhabdomyosarcoma. So here we want to see if we can subclassify these small round blue cell tumors further using karyotyping, because the treatment of all these cases is different. So the typical karyotype finding that you will find in Ewing sarcoma is a translocation between 11-22. We can also do FISH or RT-PCR to do this to detect the same fusion here. Now, in this case, you can see that there is a 11-22 translocation. This is the defining event in Ewing sarcoma, and once you get this, you can actually start therapy. So cytogenetics here helps you to classify sarcomas with the similar morphology. Moving to another case of a 58-year-old man. He presented with a large retroperitoneal mass. The tumor was around 6 into 6 centimeter in diameter. It was well circumscribed and it showed yellow areas. Now, because this is the histology, we are a little worried whether is it a lipoma, and because it's a large tumor in an old man with in the retroperitoneal location, we are worried to and want to confirm whether it is atypical lipomatous tumor or well-differentiated liposarcoma. So here we are worried and we want to differentiate from a benign, borderline, and a malignant condition, and we need to be absolutely right. So we are looking here for specifically for MDN2 or CDK4 amplification, and we're looking for these ring chromosomes. Now, this is a karyotype, which clearly shows the ring chromosome, and these ring chromosomes represent the gene amplification structures. These ring chromosomes contain amplified regions which show MDM2 and CDK4. You can, of course, do this by immunohistochemistry, but here you get a striking visual impression of what the actual genomic rearrangement is. So you can do NGS, which will detect the MDM2 amplification. But if you want to see exactly how the karyotype uh, will show you how the genome is reorganized into physical ring structures. Coming to the last case, this is a 2-year-old child who presented with an abdominal mass and bone pain. Uh, the radiologist found a mass in the lumbar region, probably arising from the adrenal. The histology was classic, where we found a small blue round cell tumor with presence of these homocyte rosettes. The diagnosis was not an issue here, it was a neuroblastoma. But to see what the prognosis of this patient is, we want to see if the karyotype shows a MYC-N amplification. Because here, if you see these double minutes, these are tiny fragments of extra chromosomal DNA scattered across the metaphase, and this indicates highly aggressive disease or poor prognosis. So, um, this, these karyotypes show these beautiful double minutes. These are the extra chromosomal um, DNA fragments which contain amplified oncogenes, and they indicate aggressive tumor behavior and poor prognosis. So sequencing will of course confirm the MYC-N amplification, but if you want to exactly visualize how the gene amplification physically occurs as dozens of these extra chromosomal fragments, I think karyotyping is a beautiful technique to see. So yes, karyotyping has its advantages, but there are certain areas where karyotyping has its limitations. Remember that performing karyotyping requires actively dividing cells, and this is a tedious process. And successful cell culture often fails, especially when you have solid tumors. This is a low resolution technique. It cannot detect submicroscopic changes or cryptic fusions, and these require FISH or NGS. And as you've seen, this is a skilled technique. It is highly dependent on the timing, the quality of the sample, how you handle it, and how you interpret it. So these are the reasons why we require a complementary approach in cytogenetics. So you always have to select the tool which matches your clinical question. So if your question is there a global chromosomal abnormality or clonal evolution, you will order a karyotype. If your question is there a specific known fusion or amplification that I'm looking for, order FISH for that target. If your question is there submicroscopic copy number variation? Am I looking for a deletion or a duplication? Order microarrays. And if there is a specific mutation at the nucleotide level that I'm looking for, I will order a next generation sequencing. So in the modern oncology paradigm, you require a number of techniques. What you usually do is you start with the morphology, and from there, depending upon what you see, you decide what step to take next. Here, the cytogenetics helps you to look at the entire architecture of the genome, whereas if you want to go deeper, you move in towards molecular genetics. So remember that all of these methods are complementary, and understanding what you need when is essential for the modern oncologic diagnosis. So my final takeaway is that precision medicine requires all these three techniques working together to dictate accurate diagnosis, prognosis, and life-saving therapy. I hope you enjoyed this brief introduction into the applications of karyotyping. Keep waiting for my other videos one by one. Thank you.